Hi, I am Grace Halsey, Senior Editor of Patient Care Online, a website for primary care physicians. And our clinical focus this month of July has been on preventive cardiology and specifically the role of primary care in helping to reduce the risk of cardiovascular disease. This afternoon, I'm talking with Dr. Naomi Fisher a little more specifically about the role of hypertension and hypertension management at the level of primary care in helping to reduce the risk of cardiovascular morbidity and mortality. Dr. Fisher is director of the Hypertension Service and Hypertension Specialty Clinic at the Brigham and Women's Hospital in Boston and is a professor of medicine at Harvard Medical School. Hello, Dr. Fisher.
Hi, thanks for having me, Grace.
Yeah. So it's been about 3 years since the American Heart Association, American College of Cardiology published its revised guideline on blood pressure management in adults that included the change in the cutoff for stage 1 hypertension going from 140/90 to 130/80. And there was a good deal of discussion around that topic, and I'm wondering if there still is controversy over the actual target or if clinicians are much more focused on simply getting their patients under control.
I think discussion is putting it mildly. You're right. When the guidelines were published in late 2017, they were met with a firestorm of challenges. They had been a long time in coming. For a very, very long time, for decades, hypertension was simply greater than 140/90, and that's the way we all learned it and we all practiced it. So many doctors and primary care physicians in particular were really reluctant to look at this new goal of 130/80 and to accept it, both for diagnosis of hypertension and for treatment goal. But in the time that has passed, I do sense a general acceptance. I think there's been a widening understanding that there is increased cardiovascular risk along a continuum and that nothing magically happens at that cutoff point of 140/90.
Right. And I believe I've read over the years too that some of the thought behind lowering the cut point was that, as you said, the disease happens along a continuum and there are already changes happening at lower levels of elevated blood pressure.
Absolutely.
And so there was also, I believe, concern that this might lead to hundreds of thousands of Americans being put on blood pressure medicine. But it also, I think it was one of the authors of the guidelines said, no, what we really hope is that it'll be a yellow light and that people, physicians, patients, will start to take lifestyle changes a little bit more seriously.
Yeah, for the vast majority of patients who fall into the newly created category of stage 1 hypertension, that is a systolic pressure between 130 and 140, we're going to be recommending lifestyle changes and not medications.
Right.
Doesn't mean it's easy.
Which sort of leads into my next question, which is, from your vantage point, how are primary care physicians doing overall in 2020 with managing hypertension? I know some things have gotten better over time, but where are the areas that specialists see sticking points or areas for improvement?
I think improvement has come in the area of increased awareness. For a long time, hypertension kind of sat in the background as a chronic disease, and we kind of skipped over it and we got to the reason that a patient was in your office that day, which could be fever or chest pain or something much more exciting. So there is definitely a widening understanding and a widening awareness that it has to be brought to the forefront. And the areas I think that need improvement are really to go further. So there is a long, long history of what we call therapeutic inertia on the part of us, we doctors, not taking care of hypertension with enough of a focus. And there's also, of course, great resistance on the part of patients. Patients don't take medications for all sorts of reasons. They can be expensive. There can be side effects that are real or perceived. They just don't understand why they need to take medication for high blood pressure. It doesn't cause any symptoms. I think our job would be so much easier if hypertension caused pain.
Yeah.
They feel fine, and they don't really want to take a medication. And of course, the therapy really starts with lifestyle modifications, and those are so very, very hard. Those are so very, very hard. So we do know that now there's an ASCVD risk calculator built into the treatment, and I think primary care doctors have been really good and quick to pick that up because they have experience in the statin prescribing world to do that.
Right, right.
But there's a lot of challenges. It's hard. And in fact, most times I would say, we have to treat patients with more than one antihypertensive medication to get them under control. So there are just a lot of pieces, a lot of stumbling blocks to get over.
And two, I think that if a patient is diagnosed with hypertension, it is highly likely that is not the only thing metabolically going on. And probably they could already be being treated for another of the.
So when we add our hypertension pills, we're adding it to a long list of pills they're already taking.